Hi, my name is Rachel Cassis, and I'm one of the internal medicine fellows, and I'm interested in medical education, and I'm also a primary care physician, so I get to talk to a lot of my patients about clinical tests, and that's what we're going to talk about today. To start out, I'd like you to take a minute and think about a time when you or one of your family members was worried that something was medically wrong, and let's say there's a test that can help us figure out if this is true or not. Think about what you'd want to know about the test and the results, what you'd want your doctor to tell you, and also on the flip side, what you would say to a patient who's in the same situation. So we're going to talk about a number of different statistical tests, and what I really want you to take from this and when I see you in class is how to apply these to clinical situations and also how to talk to your patients about it. We're going to be going over diagnostic tests, which you use when a patient has symptoms and you're trying to figure out if they have a disease, and screening tests, which you use in situations where patients don't have symptoms. We're going to use a clinical case to talk about diagnostic tests, and this is a situation that I encounter pretty commonly in clinic. We have a 30-year-old woman, and she doesn't have any significant past medical history, and she's coming in to see us with pain with urination, or dysuria, and urinary urgency. She's got to go for the past week, and she's concerned that she has a urinary tract infection, or UTI. We're going to use this case to help us answer the questions: how do we know which test will best diagnose a UTI? How do we interpret testing for this patient? And how likely is it that this patient has a UTI? And we know that no test is perfect, whether it's diagnostic or a screening test, so we use statistics to identify how good the test is and what its limitations are. For example, there are going to be some false positives, so people who test positive but don't actually have the disease we're looking for, and false negatives, so people who actually do have the disease but the test is negative, and statistics will help us and the patients to understand this. So keeping all these statistics straight can be really confusing, even if you've seen them multiple times. And one tool I've found to be helpful is using these 2x2 tables. And you've probably seen these before. On the columns you have your disease is there or your disease is not, and then on the rows you have a test that's either positive or negative. So if our test is positive, our disease is there, we have a true positive. If our test is positive, our disease is not there, that's a false positive. Test is negative, disease is there, false negative. And if our test is negative and the disease is absent, that's a true negative. Now I'm going to talk about these statistics in a few different ways, first in words and then using some calculations. So if we try to describe sensitivity, the way I think about it is it's the probability of testing positive for a disease if you have the disease. And then specificity is the probability of testing negative for a disease if you don't have the disease. And let's look at sensitivity and specificity using our 2x2 table. For sensitivity, we're looking at the fraction of people who tested positive and had the disease, are true positives, relative to everyone who has the disease. And for specificity, we're looking at the fraction of people who tested negative and did not have the disease, are true negatives, relative to everyone who does not have the disease. When choosing a test, we're balancing sensitivity and specificity, and I'm going to use a graph to help illustrate this. The curve to the right represents people with disease, and the curve to the left without. On our x-axis, we have a test result with units, and then the y-axis, the proportion of the population who does or does not have the disease. Let's first substitute our disease for a comet heading towards the Earth as our outcome, versus just normal space, and we're going to pretend there's some sort of mysterious test that can tell us if the comet's coming. And we really want to know if this is the case, so that we can destroy the comet or move everyone out of the way from where it's going. Let's say we have a test with a cutoff at line A. Positive results would be to the right of this line and negative results to the left. So we're catching pretty much all of the comets, and we're correctly identifying when there's not a comet, but there's also a lot of the time when we say a comet is there when there actually isn't. In this case, it's okay if we have a lot of false alarms or false positives because we want to keep people safe, even if we're going to have some unnecessary hysteria. This is an example of a more sensitive test. Let's say we're moving our cutoff to line B. So now we're correctly identifying when there is a comet and correctly identifying when there's not a comet, but we're also missing a lot of comets. And this is an example of a more specific test, where you're maximizing your true negatives and minimizing your false positives. If you're in the case of something dramatic like a comet or a serious illness, this may not be the way to go, and you would want a more sensitive test. Another graphical way to think about balancing sensitivity and specificity for an individual test is through a receiver operating curve, or ROC curve. The y-axis is the true positive rate, or sensitivity, and the x-axis is the false positive rate, or 100 minus specificity. An optimal test maximizes true positives and minimizes false positives, and will be represented on an ROC curve in the upper left-hand corner. We'll see this again in a later example, but for now get a sense for what this looks like. Before we go back to our clinical case, let's just do two more testing statistics. Our positive predictive value, which is the probability of having disease if you test positive, and our negative predictive value, which is the probability of not having a disease if you test negative. Using our 2x2 model again, for positive predictive value, we're looking at the fraction of people who tested positive and had the disease relative to everyone who had the disease. And for negative predictive value, we're looking at the fraction of people who tested negative and did not have disease relative to everyone that does not have disease. Let's summarize what we've talked about so far and talk about what makes a good test, which really depends on the situation. For initial diagnostic tests, we generally prefer to have more false positives than false negatives, so a test that's more sensitive. For example, let's say I'm in the emergency room and I have a patient who I'm concerned has a blood clot in his or her lung, a pulmonary embolism. This is a high-risk situation because the clot, if it progresses, could kill your patient. We have a blood test, which was called a D-dimer, which can be positive in many situations, including when there's a clot in the lung. This is an example of a sensitive test. Likely we'll catch everyone with a blood clot, but we're going to have a lot of false positives. When we're confirming a diagnosis, we generally want a test that's more specific. For example, in the same patient, if the D-dimer is positive, we need to confirm that there's a blood clot, because anticoagulants, which is the treatment for a clot, are not without risk. To do this, we get a CT of the chest to look for blood clot, and this is a more specific test to confirm our diagnosis. Pre-test probability we're going to come back to. And another important thing to know about positive predictive value is that it is dependent on prevalence. For example, I see a lot of patients who are refugees in my clinic who have chronic abdominal pain. And in this situation, we often screen for H. pylori, which is a type of bacteria in the stomach, using a blood test. The prevalence of H. pylori is quite high in developing countries and relatively low in the U.S. In the U.S., this means that the H. pylori test has a low positive predictive value, meaning the probability of having the disease if you test positive is relatively low, relative to someone from a high prevalence area. Let's go back to our clinical case at this point and try to answer the question, how do we know which test will best diagnose a urinary tract infection? A urinalysis or a urine dipstick is a combination of many different tests, and you may be asked to do one of these when you're on your clinical rotations. The main components that are helpful to determine if a patient has a UTI are the presence of blood, nitrite, and leukocyte esterase. You can see blood in a urine dipstick when there's irritation in any part of the urinary tract, but especially when there's urinary tract infection. Nitrite is positive when we have the presence of a nitrite-producing organism, which is generally a gram-negative bacteria. And leukocyte esterase is an enzyme that's released by white blood cells and reflects the presence of these cells. So the more of these tests that are positive in your urine dipstick, the more likely it is that our patient has a urinary tract infection. Let's do some calculations, and you're going to see this sort of thing on your STEP and your board exams, so it's good practice for us. Let's go back to our urinary tract infection example, and say we did a urine dipstick in 1,000 symptomatic patients who had the urinary symptoms that we described before. For 1,000 patients, let's say the pretest probability of having a urinary tract infection is 50%. That means we're going to have 500 people who have a urinary tract infection and 500 people who don't. So let's say that there are 390 patients who have a positive urine dipstick, which is confirmed by a positive urine culture. And we often send urine cultures which pretty much report how much bacteria grow in your urine sample. And we do this in patients where we're not sure if they have a urine infection, or we want to confirm our results or know what type of bacteria we're treating. Urine cultures are both highly sensitive and specific for diagnosis of urinary tract infection. They just take some time to grow, so they're not the first test that we normally do. So we would also have 110 patients who have a negative dipstick but a positive urine culture, and these would be our false negatives. We know that sensitivity is the probability of testing positive for a disease if you have the disease. In this case, our denominator is everyone with a urine infection, and our numerator is those who have the infection but who also test positive with their urine culture. So this means if you have a urinary tract infection, you have a 78% probability of having a positive test, which is moderately high, meaning that we're going to catch most people who have a urinary tract infection. Let's do the same calculation but for specificity. For specificity, from before, we know it's the probability of testing negative for a disease if you do not have the disease. So we know there's 500 people that don't have a urinary tract infection, and of these, 485 had a negative dipstick. This gives us 0.97. To interpret this, we'd say if you don't have a urinary tract infection, there's a 97% probability that your dipstick will be negative. This is a high specificity, meaning we're going to minimize our false positives. Because the urinalysis is a combination of tests, we're balancing sensitivity and specificity based upon multiple positive results. As we discussed before, each test has an optimal sensitivity and specificity based upon a separate ROC curve. For example, the sensitivity of leukocyte esterase alone is 0.62 and the specificity is 0.7, which is pretty good but not great. The calculation that we just did on the previous slides included a positive leukocyte esterase and nitrite together, and their joint sensitivity is 0.78 and specificity is 0.97, which are both higher than using just leukocyte esterase alone. So you're more likely to accurately diagnose a urinary tract infection. Your ROC curve is further up and to the left relative to just using leukocyte esterase. Lastly, let's do one more calculation, and this is going to be for positive predictive value. Using our same numbers from before, if you recall, positive predictive value is the probability of having a disease if you test positive. So this is everyone on the denominator who has a positive test, a positive dipstick, and the numerator is everyone with a positive UTI and a positive dipstick. If you calculate this out, this is 0.96. So how we'd interpret this is you have a 96% probability of having a urinary tract infection if your dipstick is positive. We know that positive predictive value is dependent upon prevalence, like we discussed with H. pylori before. So this positive predictive value is relatively high because we're testing symptomatic patients, where the prevalence of disease is higher relative to those who don't have symptoms. If we were looking at people who didn't have any symptoms, our positive predictive value would be much lower. When we're diagnosing a urinary tract infection, the stakes for the disease, the testing, and the treatment are generally quite low. We don't want to miss a diagnosis because it can progress to a kidney infection, but antibiotics are generally well tolerated, and it's okay for us to have a relatively high number of false positives. Our urinalysis is sensitive, and even if we have both a positive leukocyte esterase and a nitrite, like we talked about before, we're going to have some false positives. We also often send off a urine culture which is more specific for confirmation and to check if we're treating the bacteria appropriately. So in reality, both of these tests, the urinalysis and the urine culture, are important when we're diagnosing a urinary tract infection. All right, let's answer our second question from our clinical test. How do we interpret testing for this patient? Generally, when we're discussing statistics with our patients, sensitivity and positive predictive value are the most intuitive to understand, and it's important to think about how to explain these statistics to our patients in plain English. For example, if we're talking about sensitivity, you might say if you have a urine infection, you have a 78% probability of having a positive urine test. Or for positive predictive value, you have a 96% probability of having a urine infection if your urine test is positive. And we're going to go through some cases and examples of this when we're in class together. Let's go back to our clinical case and answer the question, how likely is it that this patient has a UTI? We're going to use likelihood ratios to help us answer this question. Think of this as a way to predict how much a test will change the likelihood that you think a disease is there. Let's go back to our example of the pulmonary embolism or the clot in the lung. Let's say I'm in the emergency room seeing a young female patient who's otherwise healthy but is a smoker, and she's short of breath. Our pretest probability in this case is intermediate, meaning maybe she has a pulmonary embolism, maybe not. And a test like a D-dimer is going to affect our decision about whether to get more testing or to treat her. So let's say we do the D-dimer and it's high. This has really changed your post-test probability. You're going to end up getting a CT of her chest. And if the D-dimer is negative, you can be pretty confident that your patient does not have a pulmonary embolism. Positive likelihood ratio is the increase in likelihood of disease if the test is positive, meaning that with a high positive likelihood ratio, a positive test is going to significantly increase your post-test probability of disease, like with our pulmonary embolism example. You can also think of this as the probability that a patient who tested positive for a disease has the disease, which is also your sensitivity, divided by the probability of a patient not having the disease testing positive. A Fagan Nomogram is a tool that uses the likelihood ratio to calculate a post-test probability from your pretest probability. The first column is the pretest probability, the second the likelihood ratio, and the third your post-test probability. In women who have one or more symptoms of urinary tract infection, the probability of infection is about 50%. This is our pretest probability. Let's say we wanted to be sure before we give antibiotics, so we get a urinalysis. The positive likelihood ratio for a urinalysis, and this is if we have a positive leukocyte esterase and a positive nitrite, is 3.4. And 3.4 is higher than 1, meaning that a positive test is likely to increase your post-test probability relative to your pretest probability. To use the Fagan Nomogram, start with your pretest probability, then draw a line through the likelihood ratio, and this will lead you to your post-test probability, which in this case is 75%. We're going to move on to our second clinical case, and this is a screening test. So now we have a 30-year-old woman, and she's healthy, and she is pregnant, and she's not having any urinary symptoms, meaning she's not having pain when she pees or going more often or having to go all of a sudden. And we want to know, should she be screened for bacteria in her urine, also called bacteriuria? Let's stop a minute and discuss what makes a good screening test. We're going to talk more about these in class. We're going to talk about mammography, colon cancer, and pap smears. For now, what I want you to know is a good test minimizes the risk to your patient, minimizes cost, it's quick, it's reliable, it's valid, and it can detect your disease before it's actually there. It should address an important health problem that is serious or of high prevalence, and there should be an acceptable treatment that's available, effective, and of minimal risk to our patient. Prevalence is the proportion of a population with a condition, which in this case is 2 to 10% for asymptomatic bacteriuria in pregnant women. There are also increased health risks for these women. You can have kidney infection, pyelonephritis, low birth weight infants, and preterm delivery. We also look at the incidence, which is the risk of developing a disease in a population in a given period of time, of kidney infection in these women, and it's also high, it's 21%. So when we're deciding if we want to screen for asymptomatic bacteriuria in pregnancy, we're looking at the cost and the risks versus the benefits. So the costs and risks for testing are you could have false positives, money and time for testing, and then for treatment you could think about antibiotic side effects and antibiotic resistance. For benefits, the testing is relatively safe, it's easy, and you also have a treatable condition. A relative risk reduction is the percent reduction in risk of disease with treatment relative to no treatment. And in this case, there's a 75% relative risk reduction of kidney infection with treatment, which is pretty high. So in this case, we have a high incidence of disease, high risk of disease, and a high risk reduction with treatment. There's minimal risks and costs with screening and treatment. So the benefits for screening for asymptomatic bacteriuria in pregnancy generally outweigh the risk and the cost. Let's go back to our case and answer our second question. Should she be treated for bacteriuria? And to do this, we're going to look at two final statistics, and these are the last ones I promise. Number needed to treat, which is the number of patients who need to be treated to avoid one bad outcome, and absolute risk reduction, which is the difference in disease rate between treated and untreated groups. So recall, if we don't treat our pregnant patient with asymptomatic bacteriuria, 21% will develop kidney infection. So our incidence of kidney infection without treatment is 21%. Our relative risk reduction, which is the percent reduction in risk of disease with treatment relative to no treatment, is 75%. So this means that our incidence of kidney infection with treatment will be 75% less than the incidence without treatment, or 21 times 100 minus 75, which is about 5%. So this means if we treat the asymptomatic bacteriuria, there's about a 5% chance of getting a kidney infection, which is a lot better than 21%. Our absolute risk reduction is the difference in disease rate between our treated and untreated group, which in this case is 21 minus 5.25, or about 16%. Our number needed to treat is the inverse of the absolute risk reduction, which in this case is 0.063. So this means that the number of women needed to treat to prevent one episode of kidney infection is 6.3. And given the low risk of treatment and the high risk of disease, 6.3 is an acceptable number needed to treat. If the risk of treatment were higher, or the risk of disease was lower, we would need a lower number needed to treat to justify treatment. For example, I often think about prescribing aspirin to prevent cardiovascular disease in older patients, and those with risk factors like smoking and diabetes. If I have a patient who has a history of a gastrointestinal or a GI bleed, the number needed to treat to prevent cardiovascular disease would need to be lower than the number needed to harm to cause GI bleed to justify treatment. Otherwise, our scale would tip more towards bleeding events, and the treatment would not be worth it. In summary, we use number needed to treat and our absolute risk reduction to talk to patients about the risks and benefits of treatment or no treatment to help them make an educated decision about their care. To summarize, statistics, especially sensitivity and positive predictive value, can help us explain reasons for testing and results of testing the patients. Screening and diagnostic tests balance sensitivity and specificity. Likelihood ratios can be used and combined to predict if a test will change the likelihood that a patient has a disease, and examining relative risks and statistics like number needed to treat can help us determine when to screen and treat patients. And if you're interested in any of the references, here they are, and I look forward to seeing you all in class.